Hello, everyone, and good evening to our East Coast participants, and good afternoon to our West Coast participants. The last webinar we had participants from all over the globe, so for those of us joining us in Europe and in Africa, let me be the first one to say good morning, because it's just about to strike midnight. Welcome to our latest webinar called The Latest on Prostate Cancer and Bone Health, which is brought to you by Zero, the End of Prostate Cancer. My name is Jamie Burst. I'm the president and CEO at Zero, and thank you to everyone joining us today. Before we start, I'd like to go over a few housekeeping items. First, as you might have heard, today's call is being recorded and will be archived on the zerocancer.org website within the next week. You should also receive an email with a copy of the recording. In addition, we're being live streamed on Facebook. So hello, Facebook. Thanks for joining us. The format of today's program will run as follows. In just a couple of minutes, I'm going to hand the program over to our brilliant presenter, Dr. Benjamin Lowentritt of Chesapeake Urology. When he's finished, he'll begin the question and answer portion of our webinar. If you would like to ask a question, we'd love to answer it for you. Please type it in the question box that you see in the webinar user screen to your lower left-hand side. You can ask a question at any time, and at the end of the webinar, we'll go through them with Dr. Lowentritt. We'll try to answer as many questions as possible. We have an hour today for the presentation, and we'll end at 8 p.m. Eastern. And please, when you close out the webinar, you'll be redirected to a short survey. It's very quick, and it would be wonderful if you could fill that out. Your input helps make our programs more impactful for patients and families. And lastly, before I jump in and begin, I'd like to say thank you to our sponsor tonight. It's Amgen. Thank you very much. We would not be able to bring you these webinars without our sponsor support. Tonight's webinar is the latest on prostate cancer and bone health. It's hosted by Dr. Benjamin Lowentritt. He's the medical director of the Prostate Cancer Care Program at Chesapeake Urology Associates in Towson, Maryland, just outside of Baltimore. We at Zero, the End of Prostate Cancer are hosting it. Our mission is right there in our name. It's to end prostate cancer. As a leader in the fight against prostate cancer, we work to advance research, improve the lives of men and their families, and we inspire action. We do that by advancing research by advocating for increases in prostate cancer research funding at a program called the Prostate Cancer Research Program that exists within the Department of Defense. We'd love to have your input and your advocacy in joining the cause and being part of the Zero team and being a champion. We improve the lives of men and their families through programs like 0360, our patient navigator program, our mentor program, where we match patients up with newly diagnosed patients to get support. And we inspire action from our Run Walk series, which we have 42 events across the country from May through November. One of our programs is happening right now, our webinar on prostate cancer and bone health. And again, our guest speaker is Dr. Benjamin Lowentritt. Dr. Lowentritt, as I said, is the medical director of the Prostate Cancer Care Program at Chesapeake Urology Associates. Chesapeake Urology Associates, by the way, is the Zero Run Walk founding partner and exists in Baltimore, Maryland. Ben is also the director of the Minimally Invasive Robotic Surgery Group and is the former president of the Baltimore City Medical Society. Dr. Lowentritt trained at Baylor College of Medicine with a general surgery residency and urology residency at the University of Maryland Medical System. He followed that up with a fellowship in robotic, laparoscopic, and advanced endoscopic urology at Tulane University Medical Center. Go Green Wave. He specializes in minimally invasive techniques to treat urological conditions and has been on the forefront of robotic urology procedures for a long time. He was also the first surgeon in Maryland to perform robot-assisted surgery for bladder cancer. Dr. Lowentritt has been selected as a super doctor by his peers in the Washington Post magazine and a top doctor in Baltimore magazine. And he's also a member of our Zero Medical Advisory Board. He's a dad and a great friend. So without further ado, I'm going to hand it over to Dr. Lowentritt. Thank you, Dr. Lowentritt, for joining us and bestowing your wisdom on us.
Well, that's, thank you very much, Jamie. I think I appreciate the introduction, and my focus is very much on prostate cancer and trying to help as many of my patients as I can, and I appreciate all of you that have logged into this, and hopefully we can start some conversation and maybe teach a few things. We have the agenda here before you of what we're going to try to talk about today. Some general things about prostate cancer, about the prostate specifically, and then we're going to talk mostly about bones and bone health in general, specifically what happens when cancer spreads to the bones, and essentially what you can do either as a patient, an advocate, or a caregiver for someone dealing with this, and ways to help handle issues related to the bones. There's going to be plenty of time for questions and answers and discussion, and really more. We'll have plenty of time at the end to talk about that, and also learn a little bit more about what Zero has out there to address a lot of these issues and needs. So just some basic things about prostate cancer. Prostate cancer is the most commonly diagnosed cancer in men, with now about 165,000 new cases estimated this year, with almost 30,000 deaths. About 1 in 9 will be diagnosed in a lifetime. These numbers have been shifting in recent years, and there's a totally different discussion that I know Zero is at the forefront of in talking about screening for prostate cancer. And that affects some of these numbers because if we don't look for prostate cancer, we may not know it's out there. But we still know that 3 million men are living with the disease, and about 30,000 men die annually with the disease. It is a disease that affects African American men more commonly than Caucasian men. And it is extremely important to recognize that not all prostate cancers are the same. And there's a really wide gamut of what you can see. Most of what we're going to be talking about today is more what we would call advanced prostate cancer, where we get into a lot of the bone health issues, but it's not exclusively so. And certainly there's information in here for people even with earlier stage disease. So what is the prostate? The prostate sits right in this area down in here between the bladder and then the remainder of the urethra. Now, these slides are actually a little bit misleading. When the actual purpose of the prostate is not to help control the urine flow, nor is it essential for erections. However, anything that we do to the prostate just because of where it is may affect those. So what the prostate is actually there to do is to produce semen. It makes about 1/3 of the volume that's in the semen. And it's also where the semen mixes from the 3 sources that create it. So the prostate itself, the seminal vesicles, and the testicles, which make the sperm. So the seminal vesicles are these little white things attached to the back here. They actually produce the most of the volume of the ejaculate. The prostate makes about 1/3 of it. The testicles make only about 5% of the volume of what's in there, but it's the most essential part because that's the sperm. The main product of the prostate, what it's making that's in the semen, is PSA, or prostate-specific antigen. Now, in the semen, it helps support the sperm to get to the egg. And the reason that it's become such an important part of our discussion in prostate cancer is not because it's only made by cancer. It's actually made by normal prostate. But different conditions may allow that prostate-specific antigen chemical to get into the bloodstream where it can be measured. So that's why it becomes such an important part in evaluating for cancer, because cancer is one of those conditions that can allow PSA into the bloodstream. So that's sort of a background about what the prostate is and what it's really there for. So in prostate cancer, some general discussion. Any cancer is named by where it starts. So prostate cancer originates in the prostate. Sounds self-explanatory, but we're going to be talking about cancer that spreads to the bones, and people want to say, oh, I have bone cancer now. Really, that is still prostate cancer that has spread. So it's just the way that we talk about cancers, it's always where it originates, because on a cellular level, that's really what the cancer is made up of. So different treatments that may affect certain types of cancer can help it even when it's spread to other areas, whereas treating bone cancer that's not related to prostate may not be effective. When we talk about staging with prostate cancer, essentially stage 1 and stage 2 are what we would call localized disease, where the cancer seems to only be within the prostate, where stage 3 is where it starts to spread into the immediately adjacent or regional areas around the prostate, and stage 4 is when it's spread remotely. And the most common place that prostate cancer spreads is to the bone. This would be an example of what we call metastatic prostate cancer when it spreads elsewhere. So another background on something that's always confusing that I know I talk about a lot is the Gleason scoring system. And I'm not going to get into depth of this at all. The most important discussion about this is that it's being simplified. So in the past, we've had these scores that are complicated, where you can have a 3 plus 3 equals 6, and it's a 10-point scale. A 6 out of 10 sounds pretty bad, but really that's the best that we see. They've effectively readjusted the scoring system where anything up to a 6 is going to be called a 1. Gleason 7 is both group 2 and 3. Historically, that would be 3 plus 4 equals 7 and 4 plus 3 equals 7. Now each have their own score. And then the higher grade cancers are Gleason 4 and 5, and those are the highest risk. So, talking about the bones, we tend to think of bones fairly simply as they're the hard structures that support the rest of the body and help keep us, in the shape that we're in. In reality, the bones are very complex, and they're constantly turning over. You have the central bone marrow that's making a lot of our blood cells that go throughout the body, and you have the actual forming of the bone that's constantly going on inside, and it's a constant breaking down and rebuilding process that we're going to be talking about here. The bones do get a little bit weaker with age. That's expected. It's partially due, though, to hormonal changes that we know we're also affecting when we're treating prostate cancer. So it's a very relevant organ system to prostate cancer overall. So this is really the crux of what we're talking about here. If for most men that have advanced metastatic, or what we would call locally advanced prostate cancer, it's important to keep an eye on bone health. We tend to talk a lot about the cancer itself and the treating the cancer, but bone complications really are the number one cause of both symptoms related to prostate cancer and eventually death related to prostate cancer, because a fracture in the wrong place can debilitate somebody and rapidly lead to deterioration. So managing these bone problems up front really have to be a part of an overall strategy to manage an advanced prostate cancer. So talking a little bit about bone loss in general, and we are going to bounce back and forth a little bit in some of these discussions. Bone loss happens to everyone. Essentially, if the bone is in a constant state of rebuilding, where it's being broken down and being rebuilt, if that ratio gets out of hand, where it's being broken down more than it's being rebuilt, then overall you're going to see a loss in the thickness or the density of the bones. And you hear a lot about bone density, and frankly, mostly it's in discussing women after menopause. But we know that especially in men dealing with prostate cancer, there is a very similar process that's going on that's causing thinning of the bone. So the different factors that cause the bones to stay more dense involve a lot of different things, including exercise and hormones, and a lot of things that we'll discuss in more detail tonight. So in men specifically, because we're not talking about postmenopausal women tonight, we're talking about men with prostate cancer. But in men, the most common causes of bone loss are use of steroids, usually higher dose steroids, heavy use of alcohol, and also very specifically men that have known low testosterone for any reason. There are a lot of men that have low testosterone naturally, and they are more at risk for bone thinning. It's not that everyone has it, but it's something that certainly they're more at risk. Specifically in our prostate cancer men, we know that we're generally treating, especially advanced prostate cancer, with medicines that block testosterone. So we are purposefully doing that to help protect for the cancer. But once again, we know that's a consequence of that is thinning of the bones. Plus, men that hopefully are living longer with their prostate cancer are having the other problems that many men, as we advance in age, have with bone thinning. An interesting thing is as we see men live longer and longer, and the whole population living longer and longer, forget prostate cancer or anything else, these problems do come up more of just general loss of bone and osteoporosis and terms you hear, once again, mainly with postmenopausal women in the past, are now certainly being discussed more with men. So when we look at the different treatments that are out there, specifically for strengthening the bone, they all have different indications, but these are the main treatments that you may or may not have heard of, and some of you may even be receiving. There's a medicine called Denosumab. That's the generic name, but the brand name, it actually has two brand names because of two different doses. Xgeva. Xgeva is the more intense dosing that's given for men that have cancer that's spread to the bone. And then Prolia, which is a lower dose and also a longer interval, that's more for the prevention of general osteoporosis or bone loss or bone thinning. That's given by a shot, either way, an injection under the skin. Also, a medicine called Bisphosphonates, intravenous or IV bisphosphonates is injection. That's a monthly injection called Zometa or zoledronic acid. And then there are pill forms of that as well. Now, both the first two, Denosumab and Zometa, have indications specifically in men with prostate cancer, and we're going to talk more about that. The pills are not actually specifically indicated for men with prostate cancer, but are more general medicines for osteoporosis. So in general, what do we tell people just to do to keep their bones as healthy as possible? Mainly, we tell them to take calcium and vitamin D. There has been some noise lately about calcium in excess causing problems with the heart. So in general, we tell people not to take more than about 1,200 milligrams a day. That's not a hard and fast rule, because if somebody has a deficiency of calcium, we certainly could give more than that. Vitamin D as well. There's a lot out there about vitamin D deficiency, and people sometimes are taking a whole lot higher doses than this, what you see on here. But in general, what we need is somewhere around 800 to 1,500 international units per day. You can get vitamin D in a number of different ways. It can be given in pill form. You see the graphic on the right side. The sun is the natural source of vitamin D for us because it helps convert substances that are already in our body into a usable vitamin D. But certainly we've known for years that milk has been supplemented with vitamin D, and now you can find it in orange juice and very many other things. I saw vitamin D-enriched bread today. It's one of those things that now is in a lot of different foods, so you may not need as much of a pill form supplement as you may have in the past, just because it's out there in all of our foods. Another way to strengthen the bones, not specifically related to calcium and vitamin D, is by exercise. Weight-bearing exercise, daily exercise of just being out there, being active, is helping the bones kind of remodel in the way that they're supposed to. And because of the added risk, we don't want somebody that's a heavy smoker or excessive alcohol, because those certainly can speed up the bone loss. So we're going to talk a little bit now about when the cancer has spread. Bone metastases, we also hear the term bone mets or just mets, are cancer that's spread to the bone. It typically goes to the edge of the bone marrow. And as we get older, many of our bones no longer have active bone marrow making blood cells. So it tends to go in those areas that still have it, which are mainly the spine, the bones of the pelvis, the ribs, and the long bones in the upper arms and the upper legs. Generally, you don't see prostate cancer spread below the elbows or below the knees to the smaller bones. You also don't typically see it in the joints. So that's, and typically people will come in and they're having knee pain and they're worried it might be the cancer. It very rarely would be anything related to cancer if it's a joint pain, because as we know from all of this, is people have arthritis that are in the age group that have a lot of advanced prostate cancer, and certainly can have both things together. So just because there's pain that you think might be related to an area of the bone, really does not necessarily mean that it's prostate cancer. Now, this last point is important, that in rare circumstances, the cancer can grow in the marrow so much that it actually can replace part of the bone marrow and affect the overall blood counts. That thankfully doesn't happen too commonly except in really advanced cases. Most of the time, I shouldn't say most of the time, thankfully very rarely this happens, but still we find a number of men that show up when they first are diagnosed with prostate cancer and they're found to have bone metastases at that time. Overall, it's only about 5 to 6% of men that present that way, but that's still the most common way that we find bone metastases. It is less common for us to have somebody that's been in our practice for a long time that may have been diagnosed years ago and then all of a sudden show up with bone metastases, although that does also happen in a delayed fashion. It's just still more common for it to happen up front. When you look at those men who do have cancer that's spread, over 90% of them will eventually have cancer in the bones. It may not be the first place it goes. It may not be the only place that it goes, but it is the most common place that prostate cancer goes. Starting kind of at the bottom of this next point first, when bone metastases happen, I said we could call it low blood counts. We sort of talked about that. Thankfully, that doesn't tend to happen very much. Historically, we saw a lot of this fourth point here, the pressure on the spinal cord. That really used to be the way that prostate cancer was found before we had a good measure to look for it, before it was symptomatic. People would literally show up with being in paralysis, unfortunately, because the cancer was either pushing directly on the spinal cord or the bones were breaking down around it and putting pressure on the spinal cord. It can also lead to broken bones in other areas, need for surgery, need for radiation treatments just to control the pain and stop the cancer locally. But thankfully, these are not all that common now, but they still do happen. So the symptoms from bone metastases, I think it's important to say that usually there's none at all. In most cases, we are finding bone metastases that are asymptomatic and not causing any pain. Certainly, that's what we want. But there are some men that present that they have back pain, and it turns out this is the cause. This is extremely, extremely rare cause of back pain, but it does happen. Also can be pain that feels like it might be in the hip area, actually is in the pelvic bones, and usually more central in that area, or in the ribs. But once again, these are pretty unusual. We talked about the possibility of weakness or paralysis, or fractures elsewhere. But really, most of the time, we're finding these based purely on X-rays, not by symptoms. So how do we find it? The most common way is a bone scan. A bone scan is a nuclear medicine scan where you're given an injection of actually a slightly radioactive substance that then travels throughout the body and is preferentially taken up in areas where there's a lot of bone turnover. And depending on how that looks on the X-ray, on the eventual scan, that can be consistent with cancer. Sometimes just plain X-rays can pick up things, although it's not all that specific and kind of difficult sometimes to see. Same thing with CAT scans and MRIs. We certainly can see them on CAT scan and MRI, but it's hard to differentiate bone metastases from some other problems on these types of scans. Or at least we wouldn't do a full body CAT scan or MRI very often to find this, because you don't really know where you're looking in many cases that we're just trying to evaluate somebody who we suspect might have cancer that's spread. Certainly if there's directly symptoms in one area, then those other scans can help. Very rarely we'll need to do a biopsy of the bone, but typically because we might see somebody who we know has a very high-risk prostate cancer or a very high PSA or a rising PSA without us knowing why, if it looks like it looks on an X-ray, we don't necessarily need to biopsy. So the reason that we look for bone metastases is many. Obviously, we always want to be as informed as we can be on the status of a cancer so we can know what to look out for. But really more and more, and this is really only over the past 8 to 10 years, there are more and more treatment options that are available if we know the cancer has spread, because there have been studies that have shown that they help tremendously. And in some cases, we want to give these treatments earlier to get a better result. So for those patients that present that have never been treated with hormone therapy that are now have cancer that's spread to the bone, there are multiple options. The foundation of all of the treatments at this point is really this third point, androgen deprivation therapy, or ADT. That drops the natural production of testosterone by the testicles. The common medications that people might have heard from this would be Lupron or Eligard or Trelstar or Firmagon. There's a bunch of them. But all of those treatments are trying to sort of stop the natural production of testosterone. In the past few years, really, we've seen that adding other treatments on top of that may help if we do it earlier, specifically looking at Zytiga, which is a pill, also known as abiraterone. It's taken with a low dose of steroid. That's proven to be very effective. And if there's a large number of bone metastases seen when before even treating with hormone therapy, you would still treat with hormone therapy, but potentially add chemotherapy and see a really significant benefit. We see this second group we call castration-resistant, which means the cancer worsening even though the patient's been on hormone therapy that dropped the testosterone. Then there really are a whole other host of treatments that are available, including Provenge, which is an immunotherapy, that same medicine, Zytiga again, and then other medicines, Xtandi, chemotherapy once again, and then other medicine that we're going to talk about, Xofigo, in a little bit, which is a radiopharmaceutical or an injectable radiation treatment. So once again, we're talking about those treatments that are specifically designed to strengthen bone in patients with metastases. So we talked before that Denosumab had 2 different doses. This is the Xgeva dose, which is a monthly dose that's been proven to reduce some of the symptoms that can develop from prostate cancer spread to the bone, and we'll get to that in just a minute. In addition, the Zometa or zoledronic acid, Xofigo, these are things that we'll talk about just a little bit more here in a minute. So once again, Xgeva is a monoclonal antibody. And I think if you look at all the drugs that are on TV now, almost all of them end with this AB. That's an antibody. So it's usually a manufactured kind of designed antibody that's using the binding. The way that antibodies work is they essentially stick to things. And by sticking to something, you can block the function of it. So what Denosumab does is it blocks the function of one of the signals that tells the bone breakdown to ramp up. So by blocking it, it allows that ratio to sort of be restored better, where there's, instead of cancer breaking down bone more, the ratio is kept where the bone's being able to be built up and organized a little bit better. What that's been shown to do is it prevents breaking of bones. It can prevent the consequences of breaking bones, like spinal cord compression, and the need for treatments down the road. What we call these is skeletal-related events. Bottom line is it affects the symptoms that can develop and the treatments necessary for bone disease worsening from cancer. It's given as an injection every 4 weeks, and we do monitor calcium levels and vitamin D levels to make sure they're not going down, because since that ratio is getting affected where bone's being built up more, that building up of bone requires calcium and vitamin D. It's fed by calcium and vitamin D. So that's important to maintain that level, so that essentially the building blocks for your bones are adequate. Also, rarely we see this condition, osteonecrosis of the jaw. The jaw is one of those areas that probably has more rapid turnover of bone, and if in rare circumstances where that can be offset, that ratio can be offset, then you can develop problems where the bone can actually grow and break down in a way that we don't like, and it can lead to dental problems. Unfortunately, that's something we see with any treatment that kind of resets that ratio, but it's rare. The bisphosphonates, specifically zoledronic acid, also prevents thinning of the bone. They do it by sort of blocking a different manner in which the breakdown of bone happens. So once again, they're just resetting that ratio to be more towards building up bone rather than breaking it down. It's used for a wide variety of treatments in cancers. It has a specific monthly dosing for prostate cancer as well, and has very similar outcomes. The difference is that we have to monitor patients because it can be it's excreted by the kidneys in a way that we have to protect against kidney damage, and people with low kidney function may not be able to get it. And there's some other little reactions just because it's an infusion. But overall, it's a very safe medicine. It's also commonly given. But once again, this has to be infused into a vein as opposed to a simple shot. So in general, radiation therapy is an effective treatment for patients that have had symptomatic spread of cancer. Unfortunately, it's very rare, and we rarely consider when we see something light up on a bone scan, unless we really just see one area and it's small, and a number of other factors are there. In general, what we believe is, even though we can only see one area in that case, there very likely are other areas that the cancer has spread to. So we don't typically radiate asymptomatic bone lesions that are seen just on a scan. So for instance, if a person's PSA just went up really high, we get a scan, there's a single spot. We wouldn't necessarily radiate that spot thinking we can cure the cancer. However, if the cancer is symptomatic, meaning there's pain related to it, radiation is a very effective treatment to help reduce the effect of the cancer in that spot. And typically it's a very short course, usually 1 to 3, maybe 5 days, as long as 3 weeks, depending on where it is and how it's having to be delivered. But, radiation is one of those things, even though it can be very directed and very localized, it can have side effects depending on what other structures might be in the path of the radiation. So depending if it hits parts of the intestine, it can cause diarrhea or nausea, and in general, it can cause fatigue, although these short courses are very well tolerated and are very helpful for people that need it. So we talked a little bit, I mentioned this concept of radiopharmaceuticals. So these are actually medicines that are injected into the body that have a little radioactivity to them once they're injected. And by being able to sort of focus the medicine to go to certain spaces, we can deliver a radioactive dose that can work just like external radiation, but might be able to go to multiple areas throughout the body and affect the cancer, specifically where it lies. So this particular treatment, radium-223, which we talked before is called Xofigo, has been shown not only to reduce pain, but also is an effective treatment to help extend life for patients that are having some degree of symptoms related to their bone cancer, their bone spread. There are older medicines. These two you see down here, strontium, samarium. They've kind of fallen out of favor because although they did help a little bit in decreasing pain, they also had a much stronger effect on the bone marrow. And so we sort of have gotten away from using those, although still they can be effective in patients that are really having a lot of discomfort from bone metastases where there's no other clear option. So the way that radium-223 or Xofigo works is it actually the body thinks it's calcium, even though it's not. It's a very similar molecule and or element, because radium is on the same column on the table, if that's something that interests you. So the body kind of takes it up in areas that otherwise it would take up calcium. But because it's got this little radioactive charge on it, it can deliver a little dose of radiation wherever there's a lot of rapid bone turnover. It's given monthly for 6 doses, so a total of 5 months. And it's very well tolerated in general. You can see some people that have diarrhea or other gastrointestinal effects because the medicine eventually comes out through the intestines. And then it can cause some of those low blood counts, but not as profound as what we've seen in older medicines. It's not given just as a pain treatment, but it certainly can have the effect of improving pain. The important thing about this is that it also is one of those treatments out there that if you qualify for it, can help in extending life, which is really what all these things are about. So finally, surgery is sometimes needed, especially if we're talking about an unstable bone, either a leg bone, for instance, or more commonly maybe something in the spine, where we're concerned about spinal cord compression or instability, and sometimes surgery is necessary. Certainly, we like to avoid that because that's traumatic in of itself, but there are surgical approaches that can be effective as well. Now, this is always not always, but more recently, this is a bit of a controversial topic. But pain medicine is very important to understand that if you're in pain and you have metastatic cancer, this is what these drugs were designed for. There's a lot of controversy out there about opioids in particular. But in the end, if you need it to have a good quality of life to get through the day, these aren't medicines that we're worried about people abusing with metastatic cancer. In fact, this is actually what the drugs were approved to be given for initially, is for patients with pain related to cancer. You certainly don't want to be taking more than you need, but it is an effective treatment. It's all about quality of life and extending life and keeping people active, because if you decide to avoid activity because you're in pain, then you're sort of really hurting yourself because the bone's going to get weaker, you're going to lose that activity, and it's much harder to build it back up. Certainly, there are other treatments other than opioids, though, Tylenol, ibuprofen, Aleve, all of these things can be very effective. There can also be injections given to specific areas if there's one particular area that hurts. But I think it's important to talk about pain with your doctor at an early stage, because you don't want to be caught behind the eight ball, and you don't want to just be toughing it out. We tend to see a lot of guys think that admitting to pain is somehow a sign of weakness. Well, it really isn't. Not only are these treatments available to you, but some of the treatments we mentioned before only become available to you once you start to talk about the symptoms that you're having. So Xofigo in particular is only allowed currently in patients having symptoms related to their bone metastases, and the most common symptom certainly is pain. So that's an important thing to discuss with your doctor. So we're getting kind of to the summary here. In general, it's important to work with your doctor or a team of doctors to develop a plan to manage your bone health. Kind of be looking out for this in advance and learn what your options are. Really important not to wait for symptoms and discuss these so that you can get on the right treatment and try to prevent some of the problems that may come out. So that kind of ends the overall discussion of the bone health. These are some of the common questions to ask your doctor, and I think these all get to what we've talked about tonight. Of course, you want to know what treatment the doctor is recommending, or at least what options there might be out there. I think that's an important subset to that, is you want to know, okay, this is what you're recommending. Are there any other options? What is the specific goal and purpose of that treatment? What might, I as the physician use to determine what treatment we're going to use? And, is there any other, like I said, other options out there? Specifically asking about what we talked about tonight. Do I have prostate cancer in my bones? Now, I didn't get into this very much, but not everybody who has prostate cancer needs a bone scan. The majority of men that present with prostate cancer present with lower risk prostate cancer. And we know that the likelihood of them having cancer in the bones is probably 1 to 2%. But even if it's there, it would be so small that typical scans really can't find it. So, we don't have the ability to take a microscope to every part of your skeleton to know, is there a cell or a group of cells that might show up 8 to 10 years from now that are already in the bones. We just can't know that. So in most cases, we're not even ordering bone scans in people with sort of favorable low-risk prostate cancer. In those patients that have either PSA numbers or Gleason score, or the way that the volume of the cancer is in the prostate, we may get bone scans at the initial workup. But obviously, then we would know if there's something visible. It doesn't still, unfortunately, mean for sure there's nothing there. we're always limited by the fact of what an imaging test can show us. So not only the question is do you have cancer in the bone, but how much is there? And based on that, what treatments are available and when can we start them? Some of these treatments we're talking about are actually not specifically targeted to kill the cancer. They're more about supporting bone health overall. So understanding what the goals are of maybe a series of different treatments that you're on is really important. Typically, just to answer this last question, most of these treatments to treat the cancer, you're going to have to wait at least a few months to really see if they've started to work. Of course, you also want to understand the risks and side effects and how those can be dealt with. Talk about some of the daily lifestyle changes that you can undertake with diet and exercise, supplements that we talked about, and of course, your loved ones are going to want to know how they can help through different levels of support. And I think hopefully there's some people participating tonight. Clinical trials are always something that should be asked about, and I think there are a lot of new options that are coming. So even if you've had some of these treatments in the past that we talked about, there may be others coming down through the pipeline of drug development and are in trials. And thankfully, a lot more attention is being paid towards some of those advanced prostate cancer patients. So new treatments are coming out every few months, it seems like. And then follow-up testing, to see how well the treatment is working every 6 to 12 months probably. So I think I might pass it back over to Jamie for a couple minutes, and then we'll take questions.
Thanks, Dr. Lowentritt. We'll jump in with questions in just another couple of minutes. I want to say thank you once again to our sponsor, Amgen, for being able to help us put on the webinar and promote it and get patients and families educated about prostate cancer and bone health. Thank you, Amgen. And to share briefly on several support programs that we have at Zero to be able to help prostate cancer patients that are dealing with cancer that has spread to their bone, and even if you haven't, if you're a prostate cancer patient or a family member or a caretaker for a prostate cancer patient, these are great programs for you to look at. The first one, 0360, is a free and comprehensive patient support service to help patients and their families navigate insurance and financial obstacles to cover treatment and other critical needs associated with prostate cancer. We're very proud that we've helped hundreds of patients so far this year with that. Focusing on getting well and fighting prostate cancer is hard enough without having to deal with all of the insurance and financial red tape that goes with that. So our 0360 program is a free program to help patients really cut through that, to help you focus on getting well and getting better and getting through your prostate cancer journey. We have our Zero Mentor program, which is a support network for newly diagnosed men living with prostate cancer, as well as men who have experienced a recurrence of prostate cancer. Our trained volunteer mentors represent many different prostate cancer journeys and have a wealth of insights to share. We are happy to match up men who'd like to get connected and maybe talk to somebody who's had a similar experience to sort of bounce some ideas off of, to share experience, strength, and hope together. And finally, we have our Zero Connect page on Facebook, which is an online support group for prostate cancer patients, survivors, and caretakers. Those affected by prostate cancer can share their stories, ask questions, and connect with others about their prostate cancer journey. And we'll provide more information, a link to Zero Connect in the participant feedback box in just a minute. We also have going on. We want to be able to understand how best to help patients, caregivers, and families be able to fight prostate cancer. We want to be able to meet the patient need and have a successful outcome for each patient, and so we can go on and have happy and healthy lives. In order to do that, we need to get information on how best to do that. So we're having our patient and caregiver survey going on right now. and we'll provide a link to that, and would hope that you'd fill that out and share some of your experience and thoughts so we can reflect on that and see what we can do to better help patients and families. And with that, we're going to move on to questions. The first one that comes to mind, Dr. Lowentritt, is how fast does prostate cancer spread to the bones?
I mean, it's a great question, and I think it's different for everybody. It generally, for the cancer to get to the bones, it's had to have been there for several years. That doesn't mean it's, because this is an asymptomatic disease, this generally doesn't cause any symptoms that people feel. It's picked up through blood testing or through an exam. We really almost never can answer that question as to how long somebody has had it. Certainly, as I said, the many men will present with it at the time of those that are ever going to have it at the time of diagnosis. Others will develop it. I've seen people develop it, 15 to 18 years after their initial diagnosis, where we could actually find it. But how long has it been there? It's probably been there the whole time. It just grows slowly. The questions of can a cancer spread to the bone and how quickly does it grow are actually two different questions. So it's not like everyone with bone cancer always has the same course. Really, it's a very challenging sort of discussion to have about the time frame that things happen, because we do see patients that show up so long. So thanks for the question. I do want to get to, I saw that it did get to the questions that were posed on the online tool. And obviously these are very specific questions, and I'm assuming everybody, I don't know if everyone can see them, but to Mr. Foreman, who has
Dr. Lowentritt, so
I'm sorry?
On the phone. Do you want me to read it out to people?
Well, it's a really long question, so let me just sort of summarize it. I can, is that Mr. Foreman was found to have, at the time of his diagnosis, it looks like maybe a single spot that showed up in the bones in the pelvis, and he's on an experimental protocol where he's actually getting a combination of multiple of the treatments that we've talked about with Zytiga and hormone therapy, and is then going to have a surgery to remove the prostate. So I didn't mention this. Typically, we don't remove the prostate when we know there's cancer that's spread. However, there are trials that are ongoing, and some trials that have suggested that treating the prostate cancer, either with surgery or radiation, even when we know it might have spread or it has spread, may still help somebody over the long run. I would say that we're not quite to the point. There was actually a news report last week out of a European conference that suggested that radiation to people that had known metastases was helpful. And I think that's very promising, and I think certainly makes a lot of sense that we may see a lot more of that. In addition, specifically, Mr. Foreman said he was found to have the BRCA2 gene. BRCA is a family of genes that are commonly tested for in breast cancer, but we now know have an impact on prostate and other cancers as well, but specifically prostate cancer. And that, that actually opens the door to another type of treatment. And what I'll say, he asked, when would we consider, should you avoid radiation therapy? There's some debate on whether or not patients with BRCA are less likely to respond to radiation. I think what's more likely is that the disease is probably more aggressive than initially understood, so radiation might have to be on a little bit wider approach, as opposed to it specifically being radiation resistant. And then the third part of the question about is it appropriate to consider a family of drugs called PARP inhibitors. Now you're really at the cutting edge. I mean, there was one PARP inhibitor that was just approved about 3 weeks ago, maybe a month ago, that's only for use after you failed a number of other treatments that you only haven't had yet, including chemotherapy. But there are a number of trials looking at earlier use of PARP inhibitors in patients with the BRCA gene. We're getting into a very, very specific kind of niche of cancer treatment, but one that's very exciting. I think given that you're already on a trial, I think you need to work through the trial to see if you get a benefit. As long as the cancer is not showing signs of coming back, then hopefully the trial that you're on will have really shown some benefit. But I would say as soon as you start to fail any of those treatments, specifically the Zytiga, if you're still on that one, then you might definitely consider a PARP inhibitor as your next treatment if you fail what you're going through now. So I know that's a very specific kind of case, but I hope that answers your question. This is actually a very good question that he just asked to follow up on it. Using alkaline phosphatase. I didn't actually talk about that and probably should have, so I appreciate the question. Alkaline phosphatase is a blood test that is a common blood test that's on a lot of basic chemistry tests that you might get along with your kidney function and your liver function. And it measures a number of things, one of which is bone turnover. So using alkaline phosphatase to check for the degree of activity in bone turnover is helpful in some patients. You might not actually see the PSA improving in some patients where they have bone disease and other disease, but the alk phos may get better, and that could be a good prognostic. That could be a good predictor for a response. So I do think that using alkaline phosphatase is helpful. There's not a lot of guidance onto what degree of drop should you see, what's a good number overall. So it's more of a trend to look at rather than a specific set of numbers. But I do like to use it for my patients because although we get addicted to using the PSA as a marker, there are some of these other markers that can help in determining how well the cancer is being treated by what we're addressing it with. So hopefully that answers your questions, Mr. Foreman. Mr. DeGudis asked about any positive results from the Checkmate 650 trial. That's a combination of two different checkpoint inhibitors. Checkpoint inhibitors are immune therapies that are specifically designed to essentially overcome the tricks that cancer plays to prevent your immune system from fighting them. So the immune system is actually our natural defense against cancer, just like it's a defense against viruses and bacteria and other things. But cancer has, like those other, like viruses, et cetera, can mutate and find different ways to essentially bypass the protections that are there. And these checkpoint inhibitors can turn that back on. You see, for a lot of cancers, you'll see these on commercials, et cetera. Now that's the hot new area of treatment. And in specific patients, there might be benefit in prostate cancer. There hasn't been a home run in that, and the Checkmate 650 is a combination of two different checkpoint inhibitors. There's some promise there, but my understanding is it's very, very, very early and wasn't overwhelmingly positive. But I think what we're going to find is there's a subset of patients that might respond to PARP inhibitors or a subset of patients that may respond to the checkpoint inhibitors and then other treatments that come down the road. All right, Shadi S. Just reading the prostatectomy a year ago, PSA 0.01. So if all you've had is a prostatectomy and not hormone therapy or any of these other treatments, then you're no more at risk that we know of than the general population. So I don't think there's a specific reason to be worried about bone thinning. Now, other risk factors for bone health in general, if you're very slight in build, very thin, if you smoke, these are things, if you drink alcohol, these are things that over time could affect you. But if you're healthy otherwise at 43, unlikely that that's going to be your primary issue, unless unfortunately the cancer comes back and you need some of these other treatments. So as I was saying before, it's not a direct consequence of the cancer. In some people, it's a consequence of the treatments for the cancer that we cause the bone thinning. Or if the bone spreads if the cancer spreads to the bone, then it can be a problem. So the next question, will the PSMA PET scan show cancer in the bone? Man, y'all are a really well-educated group. I love it. So yes, the PSMA PET scan, so PSMA stands for prostate-specific membrane antigen, does promise to show cancer sort of wherever it is, bone or lymph nodes. As it becomes more widely available, it's already available in some research institutions, then there is the hope that this will serve as a better bone scan. in addition to a lymph node scan in one. So typically we might get a bone scan to look at the bones, a CAT scan to look at the specific lymph nodes. But when we're really not sure, a traditional PET scan that might be given for other types of cancer is not very helpful in prostate cancer. So these newer PET scans can be helpful. There is one that's actually available that's a flucyclovine PET scan, and it can also show cancer in the bones and in the lymph nodes. But the PSMA is getting a lot of excitement building out there, and hopefully it'll be available within the next year to 18 months, which will then allow us to see if that works even better. You know, it's all in the experimental phase right now. How much added time does Xofigo provide? So, you know, this is a challenge with all of these. If you look at the data, it adds about 3.3 months or so. That doesn't sound like a lot. What you have to realize is that in the group that was studied, and these are patients that were already developing symptoms from their bone metastases, who had already been on hormone therapy and it had failed, and many of them had had other treatments as well. So they were very, very far along in their disease. The average life expectancy was less than a year. So giving those patients an extra, 3+ months was very meaningful. And most cancer trials only show that level of benefit. What you have to realize is that's an average. So you have patients that have lived considerably longer than that, and others who didn't even make full treatment. So, I think my strategy in all this is always try to identify the right patient for the right treatment at the right time. And I think if that attitude that's being approached, then you hope you're going to see the better benefit of each of the treatments that we give if we're giving them at the right time. Now, that's all that I see on here. Are there any others that we haven't addressed?
One that I got before the webinar was, can prostate cancer cause osteoporosis?
So prostate cancer specifically is not known to cause osteoporosis. But when we're talking about the bone thinning that happens from hormone therapy, then absolutely it can cause osteoporosis. And it is important to know that, some people who don't have spread of cancer might get hormone therapy for an abbreviated course, either 6 months or 2 years, because they're getting radiation, and the hormone therapy helps the radiation work better. There is some bone loss that can happen then. And if the hormone testosterone levels don't kick back in when those treatments are stopped, it certainly can lead to ongoing issues with bone loss. So, any history of sort of having these treatments, unfortunately, does have that risk. Now, not everyone who has radiation needs hormone therapy. Not everyone who has had surgery, most people who have surgery haven't had hormone therapy. So it's not the cancer necessarily itself that's causing bone thinning as opposed to the treatment, separate from the whole discussion of if the cancer spread to the bones.
And lastly, Dr. Lowentritt, what gives you the most hope regarding new diagnosis and treatment options for prostate cancer?
Well, I think in the last 10 minutes we talked about a few of them. I think this combination of genetics, specific markers in the cancer and in someone's own kind of immune system, and pairing those with very specific treatments, I think we're finally getting to some of these concepts of individualized, personalized treatments based on a specific set of markers. That's very exciting. Now, it's not here yet, and I think our excitement is that we see it coming over the course of the next few years. There's more and more information, like I said, weekly and monthly now coming out with all these treatments. Some are going to work in prostate cancer, some are going to work in other cancers, but finding that right combination of the patient and the treatment, I think we're going to have some really meaningful options for people going forward beyond what we've already seen. I mean, 10 years ago, none of these treatments that we've talked about tonight existed, period. So other than hormone therapy, I guess. So, we're really seeing such a tremendous growth in our options, and we're really seeing the results in our patients. These are treatments that, in general, create meaningful additional years, in meaning that they're not making the patients feel run down or so ill that they can't go on. You're not taking away good time just to add on time. You're really adding time from day one. And I think that's very important And I think all these treatments hopefully can continue to deliver on that.
Thank you, Dr. Lowentritt. Outstanding presentation, and thank you for taking so many questions and giving fantastic answers. That's
hey,
wonderful.
my pleasure.
Thanks for making time. We're going to be wrapping up the webinar. If you have further questions, please feel free to send them to me. My contact information is in this slide. As you close out of the webinar, you'll be redirected to a quick survey. Again, we value your input, so please take a minute and share your thoughts about the program so we can continue to improve. Once again, my name is Jamie Burse. I'm the President and CEO at Zero the End of Prostate Cancer. My contact information is here. You can follow me on Twitter and continue to ask away and continue the dialogue on prostate cancer and how you can get involved in the cause. And once again, thank you, Dr. Lowentritt.
Thank you very much. Thanks to everybody.
Thanks, everyone. Thanks for joining us tonight. Bye now.